Thank you very much. Today I want to talk about a topic dear to my heart, yes, yet not achievable where I'm practicing as of yet. And really I want to go over a review of the IDSA guidelines which were published in January 2007 in CID. And there's a copy for you guys up there about those guidelines. Or you can go to the IDSociety.org. And click the guidelines just to get a copy of those guidelines. Actually, they have a nice set of guidelines in that website for all ID related. The other article we'll talk about later briefly is about how reimbursable non-patient care activities from ID physicians and the value of ID physicians in that standpoint. But I just want to go over antimicrobial stewardship. It's something that's taught a lot. We academicians speak about it a lot. Yeah, it's harder to practice than it is to preach about it. And the guidelines sort of state out how you should think about setting it up and what are important issues and what are maybe less important issues. But really that's a lot to be left for the individual institution or program to be done. So we can have some discussion about that. And I know we have members from different facilities here to talk about potential differences and how you could perceive that. So what is antimicrobial stewardship?
Trying to feed antibiotics so that you don't overuse unrequired ones.
Part of it's overuse, unrequired, but there's certain areas that you should look at. Appropriate use, not overutilization, de-escalation. But there's a whole gamut of things that you could put in here. But sort of, it's looking at how you utilize antibiotics in a certain way. Dealing with first selection. And that's something we should be all pretty darn good at. That's why they consult infectious disease physicians, is to make sure we have a proper selection many times of antimicrobial therapy for a specific syndrome or culture driven. And that's the issue. Many times we are called to see a patient when we don't know what's going on. They have fever. They look septic. So they want to make sure they have proper quote-unquote coverage. The issue of coverage is either empiric, which is many times what we have to do. And in that situation, we have to really go out and on a limb and say we need to make sure we look at this as a possibility, that as a possibility, and what's going to hurt the patient if we don't cover, and cover what we can. Coverage meaning by what broad antibiotics we may have to use in that specific scenario, versus what's driven by culture or the syndrome. Community-acquired pneumonia being an easy one to go after because there's specific guidelines. If it's community-acquired pneumonia, there's certain things we should look for as far as coverage, and certain things we shouldn't necessarily look for as far as coverage. And those are more driven by that syndrome and empiric therapy for that syndrome. Now, if we have a drug and bug, for example, if we have strep anginosus, and we have a gallbladder or hepatic abscess, we kind of know where to target. We target that single microbe, and we might have to target some more because there might be more microbes that haven't yet been identified that are targeted by that same syndrome that causes that, for example, bacteremia. And I want to get a point across. People say we always have to cover for pseudomonas in a hospital-acquired infection. And many times when they're really sick, something you do. But always covering for pseudomonas does come at a cost. Anytime you use a pseudomonal agent and it isn't pseudomonas, or you leave it on for a long period of time, you over time pose that organism, whether it be pseudomonas or another gram-negative, the ability to get resistance. So I see so many times people get started on a anti-pseudomonal agent, it grows E. coli, and yet they stay on that anti-pseudomonal agent until infinitum, without the need for it. And yet you're actually allowing that agent to be utilized more and more without real need, and then resistance develops. Aside from selection, dose is important. We have a PharmD representative here. Dosing is a antimicrobial stewardship issue. Whenever I go see a patient, I try to remember to look at the MAR at all times, because I don't know how many times you end up seeing what I perceive as misdosing. Either overdosing and a relative overdosing, for example, giving, I'll pick on a drug that's not in your armamentarium, maybe imipenem 500 Q6 in an 88-year-old man with normal renal function. Well, 88-year-old man doesn't have normal renal function. You can be sure if you leave that agent on for enough period of time, your seizure potential increases. Or underdosing, using, let's say, Levaquin 250 for a gram-negative pathogen. Now, if it's in urine, you might get away with it, but underdosing leads you to resistance. So, you got to understand pharmacokinetic principles, pharmacodynamic principles, where the drug gets levels in, how it gets levels in, and the principles of time over the MIC for beta-lactam antibiotics, and area under the curve for example, quinolones or aminoglycosides. Very important principles that, we don't think about in antimicrobial stewardship. It really is, because you're trying to utilize antimicrobials well. The route administration. There are drugs that people think are nearly bioequivalent, and they're not. And there's drugs that people forget are nearly bioequivalent that are. I don't know how many times I see acyclovir, 400 TID, all of a sudden PO, and then the patient has an ileus, and they put 400 milligrams IV Q8 hours. Huge difference in bioavailability. And if that individual is quite thin and may have renal insufficiency, you may have a problem with that IV dose. Counterintuitive, people forget, for example, that metronidazole, the quinolones, and other drugs, fluconazole, have greater than 95 to 98% bioavailable. And yet, many times I see IV therapies used, PICC lines ordered and not needed because they have a intro system that would work. And the cost issues are not insignificant. Cost issues between most IVs and orals can be quite substantial. Even the generic drugs such as fluconazole has differences in oral and IV. That's a small difference now. It used to be a rather large difference. Our rep here has linazolid. There is a difference in cost in IV and oral. Same thing with other drugs. Quinolones in general do have a cost difference one way or the other. There's also not only the cost of the acquisition, but the cost of nursing time and time needed to deliver the drug. And then duration, which is probably the hardest thing sometimes to change. I always say, I say this all the time, ID doctors love football scores. We know durations in 3 days, 7 days, 14 days, 10 days, and 42 days. For some reason, we like football scores. Yet there's very little data and actual duration issues. There's certain things that I hold to the heart. For example, Staph aureus bacteremia, that is removable source. I like to give 2 weeks. Same thing with candidemia, 2 weeks if there's a removable source. But there's certain other ones that really the data is not that great. For example, pneumonia is one of those. There's been studies that show that 8 days is enough for certain pneumonias. I question that sometimes because it's hard, in my opinion, to actually give an accurate diagnosis of pneumonia. But I think sometimes shorter durations can be done. But duration may end up being realizing that you don't have an infection to start with, and you have to de-escalate or remove antimicrobials. That, I found, is the biggest hurdle. You have a person who you see in consultation doing really poorly, has a myocardial infarction, and looks septic. They put on broad-spectrum antibiotics. They get cath 2 days later. We realize they have coronary disease. And somehow the antimicrobials stay for 10 to 14 days, even though probably they had cardiogenic shock rather than septic shock. And it's so hard to remove those antimicrobials at they say day 3 or 4, when you should look back and say reevaluate. That's why many times when I see patients, I don't commit necessarily to a duration. I commit to trying to find a diagnosis, then watch them, and then if you do find a pathogen and you do know what the strategy is going to be, then you can commit to a duration. Many times you don't. The other typical example for me is someone, one of the medicine residents comes up to me, Mr. Jones we take care of his subcutaneous abscess and he's got cellulitis still. How long do I treat? Treat till it gets better. There's no right answer as far as duration. It may end up being 5 days. It may end up being 6 days, not 10, 14 days. But it's one of those hard things to figure out because people are so in the concept of trying to get the duration taken care of. I realize many times you can't predict, but if you see the sequence of improvement, you could probably predict closely where you need to go as far as duration. Other goals of antimicrobial stewardship we kind of mentioned out here. Optimize clinical outcomes by those four mechanisms: the dose, duration, selection. Minimize toxicity and adverse effects. That's where the pharmacokinetics, in my opinion, come into play. And realize what kind of drug interactions may cause. Realize that there, pick up the drug, linazolid can cause serotonin syndrome potentially. Realize that LFT elevations may end up being from your azole. Realize that a seizure may not be something for intracranial process, but rather you alter the seizure threshold by using a carbapenem. Minimize the selection of pathogenic organisms. I think we've all read enough about scenarios where people have altered the antimicrobial use in certain either ICU, hospital, or facility because in response to either high multi-drug resistant bacterial pathogens or C. diff outbreak and having a potential positive result. Put those scenarios into context because it's not only antimicrobial stewardship that plays a role there, it's infection control, microbiology, and actually practice patterns that also are altered. So you can't put it all in antimicrobial stewardship, but it is a tool in those outbreaks of resistant pathogens. Obviously, one of the goals is to minimize emergence of resistance, and one of the goals for the facility is to reduce healthcare costs. There has been an association between antimicrobial use and emergence of resistance. Like I stated earlier, if changes of use alter or paralleled by changes in prevalence of resistance. When quinolones started being used for prophylaxis in many neutropenic fevers, we started seeing in our cancer hospitals increased quinolone resistance of simple gram-negatives such as E. coli. Same thing happened a little bit with strep pneumonia for a period of time. You started seeing, for example, penicillin use or amoxicillin use in kids before Prevnar came around, increasing resistance and because of use. It doesn't have to be in the hospital setting, it could be in an outpatient setting as well. Resistance is more prevalent in healthcare-associated bacterial infections than community-acquired infections. We know that. That's because we pressure them in the healthcare facility. We do that more intensely because there's a fewer population in healthcare facilities, but overall, much more is utilized in the outpatient arena. Just realize, though, it's all open game, though, at that point. Patients with resistant bacterial strains are more likely to have previously received antimicrobials. How many people have seen, people coming back from long-term acute care facilities such as a Kindred, where antimicrobial use is heavily, or a nursing home patient? What does the doctor in the nursing home use as far as his antimicrobial armamentarium? Quinolones, maybe a Rocephin IM shot here and there. They really use the oral. So if I see a patient come in with pyuria from a nursing home, I'm going to avoid the quinolone. I'll use a beta-lactam, maybe one dose of aminoglycoside, even in a 70-year-old guy. Just because I know the quinolone has a significant chance of being resistant. I generally do not use quinolones much in a hospital setting, except for defined infections, whether it be community-acquired pneumonias or defined culture-proven pathogens which are sensitive. Areas of hospital with high antimicrobial resistance tend to have higher antimicrobial use. That's, the hospital is becoming more of mixed. It used to be the ICUs tended to have more resistance, but they also tended to have the highest use of antimicrobial therapy. But now the wards are starting to get that too, and they're catching up quite a bit, so the difference may not be as prevalent as before, but it's still there to some extent.
And we see that especially at our VA because of the spinal cord. Those type of patients, they have a lot of indwelling Foley catheters, a lot of exposure to antibiotics. They're the ones that when they get an infection, there's a lot of resistance.
Right. You can define the patient population, the spinal cord patient population. I call it also the trait population as well. You have the sputums that, for some reason, everybody needs to chase down and treat for infinitum. Those are the populations that you tend to see highly resistant gram-negative and highly resistant gram-positive organisms, because we've expressed the resistance to the max, and we've changed the flora. Increasing duration, that's what we're talking about here, of patient exposure to antimicrobials increases the likelihood of colonization of these resistant strains. Eventually, those colonized patients may have infection with these agents. And the hard thing for many of us to do is determine what's colonization and what's actual infection. And that goes back to me figuring out what's truly pneumonia or what's truly an abnormal chest X-ray from another reason in this patient who has a temperature of 100.5 and a white count of 12. Lots of potential differential diagnoses there, both infectious and non-infectious. And that's where we have to be selective sometimes as far as defining what's a clinical scenario there. And if you're going to dive in with antimicrobial therapy, try to define what you're going to do 3 days or define a period of time where you might have to reevaluate, because we all are wrong. We all overprescribe. I overprescribe because there's empiricism there. But if you do empiricism, you have to have reevaluation time. And that's critical. I like this slide. I got off the website www.despair.com. And actually, it makes sense. No single raindrop believes it's to blame for the flood. And make the analogy here. How many times have you heard, well, it's just this patient really needs it. I just want to be just in case. And you can get away with it for a single patient. If you add it, do it again, and do it again, you're going to end up with problems. You're going to end up with KPC, Klebsiellas. You're going to end up with ESBL problems. You're going to end up with highly resistant organisms. Each one in itself, not a big deal. We all do it. But you do it enough times, you have enough raindrops there, it's going to be a problem. So, the guidelines, they suggest, what makes an effective program for antimicrobial stewardship? Typically, two personnels are critical. An infectious disease physician looking over it and defining it, and a clinical pharmacist or PharmD with specifically ID training. Those two people are probably the critical elements of any program. But it may not be the exclusive, because they need to be interacting with lots of other programs in collaboration. Your clinical microbiologists to figure out what's out there, and actually communication as far as what they're seeing. Are they seeing more KPCs, Klebsiella? What do we need to do as far as if they're seeing more C. diff? If they're seeing more resistance? There has to be communication. Infection control is an easy partner there to figure out what's going on, because they are the ones that end up isolating patients or realizing that there's a problem and maybe have to troubleshoot with trying to figure out solutions to the potential problem. Hospital epidemiology, similarly looking at what's out there. What's the antibiogram of the facility? Recent antibiogram. And I had to, antibiograms are out, usually show you what's happened last 6 to 12 months. But things happen. Our burn unit, things happen in a month to change the flora in that unit because of those susceptible population. The P&T committee, they make the choices for formulary. Yet many of these antimicrobial stewardship programs put the PharmD and the infectious disease physician in sort of an antimicrobial subgroup committee of the P&T committee. So you can help the P&T make the proper decisions about formulations. The easiest antimicrobial stewardship issue and cost issue that the facility has is the formulary. It is the formulary. There's hospitals that have one quinolone, one carbapenem, one of each class, so to speak. And there's hospitals that have the gamut. And you can determine, to some degree, the availability of some of these agents and make decisions rationally about why one agent's used over another. Not all cost. It may end up being resistance being an issue. Safety, obviously, is an issue. And cost probably plays a role in many decisions, obviously. And then, one thing that I'm not good at, the IS person, the Information System Specialist Support. Electronic medical records in many facilities, not in mine, but in many facilities, and there's data mining software out there that are helping infection control people, but they can obviously help antimicrobial stewardship program define what resistance is out there, which patients to target to look at, and have real-time, actually more real-time information rather than 3 to 6 months information that may be too late to work on. Most facilities, such as mine, are pretty slow in that and not as up to date, but if you have support in that area, you could probably make significant progress in your own program. And lastly, not least, is you need support from the top, whether it be medical staff leadership, hospital administration, and providers. If you have a program started and your hospital administration does not back you up, or you don't have support from medical leadership, you're doomed to fail. You need to get them to back you up first. And it's not hard to get hospital administration to back you up because most of these programs more than pay for themselves. Maybe hospital leadership may be issues in certain hospitals, but you have to work on that before a program gets started, because if you start a program, jumpstart a program before you have their buy-in, or you have partial buy-in, there are going to be bumpy roads ahead in that program. And I like to say there's two major strategies, but there's really a mixture of strategies. One strategy is get them up front, pre-authorization. This is what some hospitals do, where they call the ID fellow for approval. And I'm gonna ask, since I don't get called for these, how many times do you say no when you get called relative to say yes? I suspect it's 90% yes, if not higher, than 10% no. What does that do? It just provides one more hoop, so to speak, for that provider to go through to acquire that agent. But it does deter some people from actually going that because they don't want to bother to that hoop. I don't find that too effective because you, most of the time, I would say, approve it because you, as the ID fellow, at home many times, because it's after hours, have a hard time realizing or figuring out at home whether this person's accurately displaying a clinical scenario or not. So as a result, approval gets on or off. When I was at residency at Duke, we had pre-printed antibiotic forms. So there were certain drugs that you had to write an indication for. That's another pre-authorization. So that's formulary restriction and pre-authorization. So that you can get them up front. It's labor intensive. That's labor intensive to do up front, and you run the risk of approving antimicrobials. The other alternative is doing a prospective audit, intervention, and feedback. What that means is, okay, you give the empiric drugs. Then you look at some time period, whether it be 24, 48, or 72 hours, or whatever time period, and then audit that chart. And many facilities will target certain antimicrobials or classes of antimicrobials, and then look back, look at the microdata, look at the clinical status. Because you can't just look at micro. You got to look at the clinical scenario, and then do a intervention and feedback either by a paper trail that's removed from the chart, or by conversation either through paging, phone call, or personal conversation if you have that opportunity. And many hospitals have a mishmash of these. But you usually have one or two of these pathways that are out there. I know one facility does mostly the pre-authorization route. I'm not sure if they do the prospective audit. Our facility doesn't have anything right now except the providers looking back and making decisions. But that's how these programs are set up. What are other salient features of a program? Education is probably one. If you're just out there telling people what to do without educating, that program won't get far. You'll make a lot of enemies. And you would have to educate. We all know you have to educate them in a way that's not negative. You have to educate them in a way that provides some true education and some true area for discussion. There may be reasons why a certain group prescribes a certain agent. You might have to go through that, and then maybe make personal changes as far as how you're going to handle that situation. But you may also educate them about the second bullet point, guidelines and clinical pathways that exist. We all know there's certain syndromes that are easily put in guidelines, and there's other syndromes that are very difficult to put in guidelines or clinical pathways. The simple ones have sort of been tiered away. The tougher ones are the complicated patients that do not fall in clinical pathways, and those are the ones that rely on more discussion. I sort of mentioned antimicrobial order forms. Nowhere in this area, I think in the Tampa Bay area, do we use antimicrobial order forms. I'm not sure if they do at your facility or not. It's all electronic. So, what? Well, that's a clinical pathway. Neutropenic fever protocol, I think it's more of a clinical pathway. Guideline/pathway. All right. So there's order forms for certain situations where you will utilize. I'm talking about order forms to restrict. You're using order forms to appropriately utilize, which probably is also a mechanism for antimicrobial stewardship. So they exist, but they could be. There are some programs that actually are more aggressive, to say the least, in utilizing those antimicrobial order forms. The fourth bullet point is dear to my heart. We seem to have the hardest time doing this. And if I had a t-shirt or I could wear something in my coat, it would be the term de-escalation. People have a hard time with this. There's a couple reasons why. You put them on that broad-spectrum carbapenem. Patient gets better. Tell the patient where you're going to narrow antibiotic coverage, but mommy's doing well now. Don't mess with it. Education is needed there for both provider and for family member or patient, if it's the right thing to do. Obviously, you have to be certain that you know what you're de-escalating to. But de-escalation, many times when you have especially when you have culture-proven, that makes sense, diagnosis, it should be done. Streamlining is another word for that as well. And many times that also means reevaluating after a syndrome whether you had the right diagnosis or not. Like I said, many times we pour it on empirically because they're sick, and we realize later on what's happened. We gotta be prudent enough to remove antimicrobial therapy or narrow it when it's necessary. I find this very difficult for some providers, many providers, and one of those thorns in my side that I wish I could correct more. More good would be done by targeting that than any other area, in my opinion. Dose optimization. Obviously, we talked about this earlier. You need to know, don't underdose these individuals. You're just adding subtherapeutic drug levels to an organism. You're just asking for resistance. And let's not forget, there's many studies of one-dose antibiotics changing resistance. One-dose antibiotics that we used to use for the American Heart Association guidelines for endocarditis prophylaxis would change microbes, the flora, very easily after less than 24 hours. So we got to realize that even certain small doses can give you, short doses can do it. And if you're doing low doses, it's like the HIV patient with the subtherapeutic antiretroviral therapy. What's going to happen? They're going to get resistance. Same thing with bacteria. And then other programs are easy, low-hanging fruit as far as cost. It's a parental to oral conversion. That goes with antimicrobials and some non-antimicrobials, whether it be H2 blockers, PPIs, and antimicrobial therapy as well, whether it be the azoles, the quinolones being the easy classes to go after. But there's others as well. What strategies the guidelines suggest are not so recommended because there's not good data for it. Antimicrobial cycling. I don't know if we still do that at one of our facilities, and the data is really not there as it's being successful. And there's questions about why this occurs. And it's because I think, and what people think, is that it would work if you cycle not every quarter, but maybe annually. Because those microbes that you select that after a quarter, after 3 months, may actually still be in the environment for 6 months more. And maybe a longer duration of cycling will be required. Yeah, you're not going to completely cycle a drug out of the system. How are you going to completely cycle a carbapenem out of a neutropenic fever population? It is hard to completely get it out of the whole facility. So it is very difficult to do, and probably that's why you're seeing less efficacy than you should potentially see in this setting. Combination therapy, another issue. We had to double cover Pseudomonas. There's really little data that double covering Pseudomonas actually provides any efficacy over single coverage of an effective agent. Now, it does have a role in empiric therapy. And again, empiric therapy because you don't know what's going on. You don't know what resistance may be there. So double covering because of different mechanisms of action from the antimicrobial and because of different resistance mechanisms may be prudent. But once you have a pathogen and you know there's control of the situation, that may be 3, that may be 5 days, that double coverage may not be necessary in many situations. That doesn't apply to some synergistic combinations for endocarditis, for example, where there's data for that. But it applies for, like I say, the double covering of Pseudomonas or some gram-negatives, which seems to be pervasive in doctrine, and yet there's really not much data out there. If you show me data, really good data, even the community-acquired pneumonia guidelines, the hospital-acquired pneumonia guidelines really don't point to any definitive data that double covering Pseudomonas is the way to go. Now you have to cover it with an agent it's sensitive to. And that's a problem sometimes because we have resistant gram-negatives out there, especially Pseudomonas. If you want to start a program, you have to be able to show outcomes. Because you want to be able to first make sure that you show your administrators or hospital leadership, I'm doing a service, I need to continue to get paid. So there's several ways you can do this. The easy way to get to people's heart is to go after their pocketbook. All right? That's why you're mostly being hired by the administrators. All right? You can use the cost of antimicrobials used either in defined daily dose per patient day, which is one mechanism which defines a dose and leaves a cost out of it. You can interpret it later on, but you can use that same data year to year because the cost won't fluctuate because it's not a cost issue. It's a defined daily dose. Or the antimicrobial acquisition cost per patient day, which is what many facilities do. And you got to realize that antimicrobial costs probably increase annually at a certain percentage point. Although this year there may be deflation. Who knows? Other things you can look at is degrees of antimicrobial resistance, either through an antibiogram or through another mechanism. And if you had a problem in an area before you started the program, or during the program, and you targeted, you can show at least potentially a sequential improvement because of, well, at least in part of your targeting. You can take credit maybe where credit may not be due, but if you can show something that's done as a result of it, you might have one significant amount of points. Look at safety. Look at the number of adverse drug effects. And I always, like I said, I picked this, for this lecture I picked on carbapenems and seizures. You can say how many seizures resulted from a carbapenem use. If you have 3 the year before and you have 0 the following year, that's an improvement. It's low numbers, but it is an improvement. Or the rate of C. diff infection. Other ways you can do it is performed by guidelines. Say you got providers out there that seem to be very independent and want to go outside the guidelines and use whatever they want to use. If you're able to alter the practice to more times using a pathway that's evidence-based or a guide that's evidence-based, you could potentially, improve other outcomes by that. Not everybody should be pigeonholed in a guideline. But guidelines are usually there to get the majority of the patients that have a certain syndrome. Not everyone, a majority. Or you can have an outcome that's independent, individualized for the institutional need. An institution may want to choose a specific guideline or outcome that's not any of the above to choose it. As long as you provide a service. But you have to try to define these before you start, if possible. Some of these may end up being evolved as a result of issues that arise. But it's better if you actually define it earlier on. Avoid the perception of cost only for the medical staff. What's going to happen if you start a program? Oh my gosh, Dr. Montero's here. He's going to make me stop all my antibiotics. Oh, he's just doing it on cheap so he looks good and he can get his fat contract. That's what's going to be said. You got to focus on quality issues to these people. Focus on issues and show them the quality issues are not altered. Show them the length of stays are okay. Show them rehospitalization rates within 30 days is actually maybe lower going through the clinical pathways rather than those individual ways. Show them mortality data or any other data that may actually prove your point. But you got to show, medical staff are going to be very not happy to be told what to do. No, that's one thing about medical professionals is we don't like to be told what to do. We've been told what to do by our third-party payers, by our patients, their families, our attendings. Everybody's telling us what to do. We like to do things that we think are correct. Yet many times, doing that, to a certain degree, you lose control. So to do that, we got to make sure that you avoid the perception of that you're doing this for cost only, but look at quality issues. It's very important. Again, if you don't do this well, your program won't be long. It may be long-lived, but won't be long liked by the medical staff, which can be your key ally or your key enemy in this situation. At a local hospital that I practice at, I want to show you what kind of costs we're talking about. Let's say that a local hospital has a cost per patient day of $20, almost $21 of antimicrobial use per patient day. With the volume of, we have 800 patients or so. UHC is a University Health System consortium. There's a consortium of hospitals out there that they benchmark. And they actually have to sign in somehow. This hospital is a part of that. Those without an antimicrobial stewardship program have a cost per patient day of $19.90. Those with an antimicrobial stewardship program have a cost per patient day of $12.83. Significant cost differences. Actually, that's about a 30% reduction at least from the local hospital that I work in. For the hospital, with that amount of volume that's in there per patient day, a $1 reduction in cost per patient day, a $1 reduction from 28.98 to 19.98 annually results in approximately $300, maybe $315,000. So if you're able to go from 20.98 to, let's say, 15.98, which seems achievable, that number becomes approximately close to $1.5 million. You can easily pay for an ID physician, 4 ID physicians, PharmD, information systems, that kind of stuff. You should realize, though, you may not be able to entertain getting that to that rate all at once, but you should be able to get a lot of it early on. The problem most antimicrobial stewardship programs have, they have great numbers first year, second year, because that's when the program starts. Then eventually you level off. You can only get to a certain level, and then you level off. Then it's hard to sort of justify, and you got to make sure you realize, hey, don't forget we were way up here 3 or 4 years ago. But you should be able to realize, they should be able to realize that after a period of time. So this is the cost issues, and why these programs more than pay for themselves and should be sought out by most hospitals. This same hospital was asked by a JCO mock surveyor, why do we don't have one? Because it's actually being thought of by the Joint Commission as one of those things that should be instituted in major hospitals. Outpatient. Go to the outpatient area for a bit. These numbers I'm not sure are accurate, but they're probably, if anything, maybe underestimate what's happening out there. Infections are a leading cause of physician visits annually. I think that's true. Over 20 million visits for respiratory infections? That may be an underestimate if you include sinusitis, bronchitis, all those in there. And about over 10 million visits for UTIs? That may be true if you include the pregnant women in there as well. Luckily, over the past few years, we've made significant progress, especially in the pediatric population, as far as declining antimicrobial use. The problem is not using the penicillins anymore, or the amoxicillins anymore. They're using the macrolides or cephalosporins now more often. So, while the usage has gotten less as a total percentage of visits for viral URIs, they tend to be using much more broader oral agents out there than they used in the past. So, the empiricism even works out there in the outpatient arena as well. Part of it we always know is perceived and sometimes true expectation of the patients and their parents to receive a prescription during a quote-unquote sick visit. Now, the pediatricians are able to start doing this to some extent, and I realize it's still happening quite a bit. But with enough education, it does work. The problem is, it doesn't really fit in well with your 10 to 15 minute patient slot when you have the next patient waiting to talk to him about 3 to 4 minutes about this, because it really takes a toll on your time. And as a result, you have less time to deal with the real patient issues that may be there, whether it be coughing due to reflux instead of bronchitis, or coughing due to asthma instead of bronchitis. And there's, detailing from pharmaceutical industries provide samples, great need, but they also provide samples of usually broad spectrum agents that are out there. And as a result, those are agents that sometimes are used. And with the new pharma guidelines, people worry that these agents are being used because of recognition of something on a pen or a mug or who knows what not, which I think it's a bit ludicrous, but it is somehow been shown in marketing initiatives in the past. to the point where it's perverse. You have a comic here. Don't forget to take a handful of complementary antibiotics on your way out. Obviously, that's not the way it is, but it sometimes seems that way. If you don't leave with something, or if you don't give the patient something, either a prescription. Hey, I know internal write prescription. Exercise 3 times a week for 30 minutes, whatever. We don't do that. We tell them what to do. But if you have a prescription, it has more weight on it, and sometimes you might have to just write it that way, so they see it as a prescription. But they seem to have to leave for a period of time to leave to get something. Otherwise, they feel empty-handed. If you go see a provider, you spend half an hour waiting for a provider. You go in, you talk, you have 5 minutes maybe with the doctor, and you leave. You feel empty-handed as a patient. So it's one of those things that you have to make sure that their visit's worthwhile by education or by other means. Issues of arising in the outpatient arena from overutilization. Over the years, we've seen increasing resistance to strep pneumonia, H. influenza, Varicella catarrhalis. Actually, the one thing that's actually reversed it to some extent is the pediatric Prevnar vaccine. It actually decreases colonization in some of these individuals, and actually decreases colonization in the adults taking care of these pediatric populations. So if anything, that's actually helped us more than hurt us significantly. The collateral effects we've talked about. For every drug you use, you're going to change the flora, whether it be your gut flora, whether it be your oral flora, whether it be your respiratory flora. And they may develop help develop resistant gram-negative pathogens. Adverse effects, all drugs have a side effect. I tell people that all the time. Tylenol has a side effect, aspirin has a side effect, all drugs have a side effect. You guys don't realize how many people go to the emergency rooms because of a drug reaction. And many times it happens to be maybe a penicillin drug reaction or a cephalosporin drug reaction. And those lead to, ER visits, costly ER visits, Solu-Medrol being given, Benadryl being given, Epi being given, who knows what's being given. But, for a viral URI, kind of sad, but it does happen. And we are making these guys. This is an old slide because it's strain in 1997. Strain in 2008 is pretty strong too. You're the next class of drug-resistant bacteria. As humans continue to abuse and overuse antibiotics, your ranks will swell. Go out there and mutate. And remember, which does not kill us makes us stronger. And that's true. That does not kill the bug, and you give more influence. More will make him stronger. So we have more resistance as a result of that. The other thing that's scary is the antibiotic armamentarium is decreasing due to increasing resistance to current agents, coupled with the lack of new drugs in the pipeline. We have very limited drugs in the pipeline, near-term pipeline and long-term pipeline. We pretty much have to use what we have, except for maybe 1 or 2 agents that may come out in the next few years. So antimicrobial stewardship should extend the effectiveness of the current agents and needs to be utilized appropriately. You think about it, agents out there's not many new ones out there to come out. What you have is what you're going to work with for a while. I left you 2 articles to look at. The first one here is the IDSA guidelines. They actually were in 2006, but they were published in CID early in 2007. And it's what I based this lecture on. The second one actually just came out in October 2008 in CID, and I think it's interesting. It's the value of an infectious disease specialist for non-patient care activities. One of those being antimicrobial stewardship. And it actually has a table in there of certain programs and what they've shown as far as cost savings, even after the cost of the ID physician, even after the cost of the PharmD, after all those costs. It also has other programs, and I think Dr. Sennett usually likes to tell people, you can make a living seeing patients, but the ID physician probably can make just as much money and sometimes more by non-patient care activities. Don't forget, contracts for antimicrobial stewardship, contract for infection control, hospital epidemiology, what else is there? There's a few other things. P&T. You can help with your formulary in the hospital setting. Contracts are a way to go, and that article helps you negotiate potentially that contract and looks at the data that's out there now and provides a starting point for you to make the initial discussion. So I think it's good for some of you guys who are going out to practice next year to actually have that article to refer back to. That's the end of my short lecture. I want to at least get an overview of antimicrobial stewardship. I hope my hospital will. Actually, we're in the works of trying to get a contract at our hospital. It takes time. I think it will happen. We're probably looking initiation in springtime, maybe summer, depending on when they get the PharmD rolling. Eventually, I'll probably have one of the fellows help and assist, because I think it's an educational opportunity and a quality assurance issue as far as training you guys, so you guys understand at least a concept. Actually, a couple concepts, because we have other facilities that do different things. When you're out in the world, you have to market yourself both for clinical care, but also for non-clinical patient care activities. Any questions?
Just a comment. It occurred to me, the cartoon that you showed at the end, that how little has changed in 11 years, and we can just easily change the year behind the bacterium in the talk.
This is nothing new. That's a sad thing.
Yeah, 11 years and there's absolutely no change.
Certain places have actually done that. You look at the University Health System Consortium. Those hospitals that have those programs. Now, many of those hospitals have it relatively easy because they have one provider source. They all may be university-based providers. Certain hospitals, like the one I work at, don't have that. So you have different providers from different institutions, and that tends to be harder because there's more discussion and play against each other, and that may be an issue. I think the VA system has one way of handling it because they have one person that they have to speak to, one provider source that provides situation, and you can potentially not the word strong, but you actually help them mold their therapy or their practice because you have more authority to do so. Some university hospitals have that same thing. Community hospitals, I think, have it a little harder because of the myriad of private providers. They have to try to make sure that they can gain patients from the community, so they don't want to upset their providers. Whereas the university-based, strictly university-based, and maybe strictly VA because they're all one type of provider, maybe a little bit more simple, or at least easier to manipulate. Although they have their own issues. Well, one thing that I thought that I lack is a good IS, information system. I think that can be a tool if you have somebody that's really good for you.
And even to make the IS person, to make them worthwhile, you really need to have a fully computerized
Yeah.
system. Because if you had an IS person and a hospital that's still using paper, it doesn't matter.
Well,
You have to have a system that's fully computerized so you can data mine the information.
Right.
So you can go back and look.
There
This wouldn't change.
there are data mining programs. I know we're looking into Theradoc as a data mining program. Even though we have a paper chart, our hospital has not 1, not 10, not 20, not 30, but I know over 50 to 80 potentially different software system it works on. And they don't talk to each other. That's a problem. That's a real problem. I go to the emergency room. I can't do the radiology. I can't even see where my patient is. I have to ask. The emergency room seems like a different hospital than the rest of the hospital.
Maybe we could get the information from the pharmacy data system because pharmacy.
Well, Theradoc helps you do that and antimicrobial data. It helps, and pharmacy data. So you're able to do that. It helps out with infection control and it helps out with antimicrobial stewardship. So that's where we're looking into because we don't have a viable electronic medical record. All right. Thank you, guys.